Today, our integrated broadcast will be on the topic of pregnancy-induced hypertension. And this session will be conducted as a role play done by the group members. There will be a patient, a house officer, the consultant, and the senior registrar and a nursing officer in this couple of scenes ahead. And we will be describing in certain instances where necessary. So we'll start. This is the session outline. We'll go through with each scene and the explanation, and we'll explain the important things in the history and examination and the management, both the initial management and the management of hypertension and the inward management, and the rest of the things that is shown here. So our case scenario is a pregnant woman of a period of gestation of 29 plus 3, and she is coming with hypertension diagnosed from a private practitioner. Here, there's a house officer who is clerking another patient, and he's being warned by the nursing officer of this certain patient.
Doctor, patient කෙනෙක් ඇවිත් ඉන්නවා. එයාගේ BP high, urine ward test එක 3+. පොඩ්ඩක් ඇවිත් බලන්න පුළුවන්ද?
Thank you miss. මේ දැනට එහෙනම් ඇකියුබේට් එකට දාගමුකෝ. මම මොනිටර් එකක් දාන්න. මම මේ අම්මට කියලා ටග් ගාලා එන්න. පැට් එක නෙගටිව් නේද?
ඔව් ડોක්ටර්.
හරි එහෙනම්. අම්මා මට පොඩි හදිස්සියක් අමාරු patient කෙනෙක් ඇවිත් ඉන්නවා. ඉතින් මට එයාව බලන්න හදිස්සියේ යන්න වෙනවා. මම ඉක්මනට එයාව බලලා ඇවිත් අම්මත් එක්ක ඉතුරු විස්තර කතා කරන්න. හරි නේද? අම්මා මම තමයි මේ වාට්ටුවේ ડોක්ටර් දිල්ෂාන්. මම අම්මාව බලන්න යන්නේ. අම්මා නේද ප්‍රෙෂර් වැඩි වෙලා ආවා කිව්වේ?
ඔව් ડોක්ටර්.
අම්මගේ නම මොකද්ද?
මගේ නම මනීෂා.
මිසිස් මනීෂා. ඔයාගේ වයස කීයද?
26යි ડોක්ටර්.
එතකොට මේ වගේ පළවෙනි බබාද?
ඔව් ડોක්ටර්.
කලින් බබාලා හම්බෙන්න ඉඳලා නැති වෙලා එහෙම තියෙනවද?
A small break here. You all are doing it live or recorded? This is
Live, sir.
Right. Okay. So then I'm coming in now. What was the last question?
The house officer is asking the relevant details.
Details.
Okay, sir.
මම ඊ උත්තර දෙන්න දැන්.
මේ පළවෙනි බබාද?
Patient is not talking. Patient is on the floor fitting. What happened?
So because of the fits.
Yes. So why did she get a fit?
Because of the elevated blood pressure.
Right. So one of the key things I want to tell you in your history taking. Now, is this emergency or a normal case?
Now this is an emergency, sir.
Right. So emergency, how would you should approach an emergency?
In this
so you
cases,
started out very well, right? You introduced yourself, nicely came, and you identified the patient properly, and then you went to normal history taking. Right. So normal history taking. By the time you finish the history taking, maybe if the real patient comes, the patient will be in the flow. If the patient is bleeding, she will be dead by that time. So the moment you see a patient with hypertension, you have to think of what?
Whether this is preeclampsia or whether she can go into eclampsia and
eclampsia, right? So the first thing you are going to ask now, try to do that with like that, and then right. So there are a few questions you ask first. If there is a negative only, you will continue history taking. If any of the, let's say, patients say headache, visual disturbance, you don't ask about whether palaviniya, devaniya, tungganiya, navaniya. It doesn't matter. You have to. It's an emergency. You have to call for help. You have to do your ABC approach. Everything. Okay. So when you come, right. Okay. So start like that. Very good. But I like your presentation. This is something I really wanted you all to do. Right. So this is why I'm very happy for you guys. And I told you whoever came to do something out of the box, and this is out of the box. Very good. Right. Very, very impressed. Right. So sorry to disturb you, but I thought otherwise people will get the wrong message. Right. I wanted to stop that. That's why I stopped you. Otherwise, I would have waited till the whole thing finishes, but I thought you can change it. Right?
Okay, sir.
Probably you are ready for that. Yeah? Okay. Start again from I am Dr. whoever.
අම්මා මම තමයි මේ වාටුවේ ડોක්ටර් ඩිල්ෂාන් මම තමයි අම්මා බලන්න යන්නේ අම්මා නේද ප්‍රෙෂර් වැඩි වෙලාවේ
ඔව් ડોක්ටර්.
දැනට අම්මට මොනවද තියෙන අමාරු
එහෙම අමාරුවක් නෑ ડોක්ටර්.
ඔළුව කැක්කමක් ඇස් බොඳ වෙලා එහෙම පේන ගතියක් තියෙනවද
නෑ ડોක්ටර්.
පපුවේ කැක්කමක් එහෙම තියෙනවද
නෑ එහෙම නෑ.
බාඩ රිදෙන ගතියක් කකුල් ඉදිමුණ ගතියක් එහෙම තියෙනවද
නෑ ડોක්ටර්.
හුස්ම
No pain
ගන්න අමාරු
vomiting.
ගතියක් එහෙම තියෙනවද
නෑ ડોක්ටර්.
වමන යන ගතියක් ඔක්කාරයට යන ගතියක් එහෙම තියෙනවද අම්මට
නෑ එහෙම නෑ ડોක්ටර්.
හරි
That's it. That's all you need to ask. Now you can continue. Now you can continue history taking. Right. Now start. And you have to check your blood pressure also first before starting the history taking, because this comes together when you are assessing blood pressure. You tell whatever the blood pressure you want to say. At the moment, normal, slightly high only, not 180, 120, or not severe hypertension. Okay? Yeah, okay.
අපි එහෙනම් බ්ලඩ් ප්‍රෙෂර් බලලා මිමු මිස් මෙයාගේ බ්ලඩ් ප්‍රෙෂර් වැඩි 150/100 වගේ තියෙන්නේ අපි මෙයාට අපි මුලින් මෙයාට කැනියුල එකක් දාගෙන බ්ලඩ් ඉන්වෙස්ටිගේෂන් ටිකක් අරගෙන යූරින් ටෙස්ට් එකකුත් කරලා යූරින් ප්‍රෝටීන් එකකුත් රිපීට් කරමු මෙයාට අපි ලැබිට්ලෝල් ඕරල් ලැබිට්ලෝල් 200 එකකුත් පටන් ගමු ස්ටැට් ඩෝස් එකකුත් දෙමු half an hourly blood pressure monitor කරමු මම ප්‍රෙෂර් මොනිටර් කරනම් BB chart එකක් දාන්න input output chart එකකුත් පටන් ගමු BBS එක බලමු මම ස්ටාර්ට් කතා කරන්න අම්මා බය වෙන්න එපා ප්‍රෙෂර් ටිකක් වැඩි අපි බෙහෙත් ටිකක් දෙනවා බබා හොඳින්ද කියලා බලන්න පටියකුත් අපි දානවා මම ලොක් ડોක්ටර්ට කතා කරලා කියන්නම්
හරි ડોක්ටර්.
Very good.
Okay, sir. So, okay, we'll just go to a little bit of information in between. So now this patient, since she had high blood pressure of 160/100 on this presentation, so we can diagnose of her having hypertension. As in the previous lecture before, we have this classification for hypertension diagnosed before and after 20 weeks of gestation. And one thing that we need to mention specifically is that in order to diagnose preeclampsia, proteinuria is not essential. We can diagnose preeclampsia with just de novo hypertension after 20 weeks of period of gestation, either with the proteinuria and or just simply having end organ damage like acute kidney injury, liver dysfunction, neurological features, any fetal growth restriction, or any features of hemolysis or thrombocytopenia. So we will be doing investigations in order to find out these specific facts. And I'll run through the history and what happened earlier. So the house officer immediately attended to the patient because having a high BP in a pregnant mother is an emergency, and as mentioned, it could lead to eclampsia, and the mother could worsen, and the worst outcome will be maternal fetal mortality and morbidity. So in the history, we have to ask when was the high BP first noted after making sure the mother is stable, because this could either be chronic hypertension or any kind of hypertension which is arising after 20 weeks. You all might have noticed that he has asked about headache, visual blurring, chest pain, and all those symptoms, which is suggestive of preeclampsia and any worsening of the condition of the mother. And additionally, we can ask whether she is taking any drugs, specifically whether she was given aspirin beforehand.
Sorry, I'm going to stop you there. It's called eminent eclampsia, right?
Okay,
Eminent
sir,
eclampsia means, because preeclampsia is something else. Eminent, she is about to throw a fit, and that is an
Yes.
emergency. Okay? If
Okay,
any of those symptoms are there, we have to stop what we are doing and give her, the management has to be started quickly. Okay? Right. Okay, go ahead.
Okay, sir. And these things you can see here, whether there was any albuminuria beforehand and whether there were any previous hospital admissions which she had to be treated with IV medication, and whether she have any scans that say fetal abnormality, specifically IUGR, because in preeclampsia and gestation hypertension, there's a risk of IUGR. And the investigations mentioned here were these things, and we have, in the examination, the house officer should measure the blood pressure and do these things and assess for any kind of heart failure, liver failure, liver tenderness, and we have to specifically assess for reflexes, patella and ankle reflexes, because it's a specific sign of eclampsia, imminent eclampsia. And also fundal examination we can do, and if there are any findings, it may suggest that the mother is having something that is chronic, not just gestational hypertension. So we move on to the next one. Here it's the ward setting, and the house officer is now trying to alert the senior personnel about this patient.
So just one more thing before starting. Okay.
Yes.
Just so one more thing, because now one of the things we check is yes, knee reflex, but clonus is the one which really, it's a more objective assessment, right? So clonus you have to check, because most of the women will have some kind of increased reflexia during pregnancy, so we can't get that. But if there's clonus, we are 100% sure that this patient have a hyperreflexia. Okay, right, go ahead.
Sorry, I missed that up. Okay, so let's move on to the next scene.
Is everything okay? I can't hear you guys.
Just a moment, sir. There's a little small
Right,
technical
okay, that's
difficulty.
fine. Okay, that's fine.
Hello.
Hello, I'm Dr. Dilshan, house officer from Ward 3. Can I speak to Dr. Deminta? Hello.
Hello. Yeah, it's Deminta here. Go on, Dr. Dilshan.
Sir, we have a 26-year-old patient in her second pregnancy, in POF, period of amenorrhea of 29 plus 3, coming with uncontrolled hypertension, with a proteinuria of plus 3 diagnosed from outside. On admission, her blood pressure was 150 by 100. There are no features of suggestive of impending eclampsia. CTG is normal and fetal movements are there.
Okay.
I started her on oral Labitol 200 stat dose. Blood investigations, UFR has been sent, sir. I think it's better if you could attend to this patient, sir.
Okay. So currently the patient is stable and she's not having any signs of impending eclampsia. I'll be there. I'm just getting out of the theater. I'll be there in just a couple of minutes.
Thank you, sir.
Very good. Right. Just a small refinement, I would say. Is that okay if I do like this, or I want
Yes,
me
sir.
to finish
Of course.
Finish
It's
until
all
the
right,
end
sir.
and do it? Right. Okay. So it's excellent. So this is, you used something called SBA. I don't know whether you are aware of that, but slightly different version of it. So just that's the refinement I want to do. SBA is a way of communicating with colleagues and patients or anybody, right? So we use it for communications. Now, SBA, the first thing is the situation. Now, let's say now this is okay in the morning hours, like the way you presented, but imagine that you are talking to your son at 2 a.m., right? So when you say we have a patient, a 25-year-old primary gravida and 24 weeks and all that, you doze off. So the first thing you have to say, so we have a severe preeclampsia patient. So that wakes you up and you are ready to listen to all this. And then you start saying that she's a 28-year-old primary, exactly the way you said severe preeclampsia later, just start off with and then do exactly the way you did it. It's absolutely perfect, right? So well done, well done. I'm very impressed with you guys.
Okay, sir. So we actually prepared a little about this communication method as well. words ISPAR stand for identification with who's the caller and the situation as mentioned, what we are having here, and any background information about the patient, like the relevant information like the the age and parity and other relevant information. And A stands for assessment, and if we have done any kind of assessment on this patient, and if we have found that anything wrong or anything to suggest that whether the patient is stable or not, we can add that as well. And the R specifically stands for recommendation, and we can tell whether the patient, whether what we think, whether this senior person should come or should just give his opinion or not, and whether there is any emergency that they should attend themselves. So that's it. And so initial management, in the earlier scene we mentioned, the HO has sent some investigations. They usually include the full blood count, urine full report to check for protein, and renal function test, liver function test, and PT-INR, and also grouping and DT, because in this kind of patient we can expect the necessity for a surgery as well. So in that case, grouping and DT is necessary. And the renal function test, liver function test, and PT-INR is there to assess whether there have been any organ damage. And monitoring, as he mentioned, since this patient is having high BP, we can monitor BP half hourly initially. And the urine albumin level we are measuring daily. And we can give the mother the kick count chart to monitor the baby's well-being. And we actually in the initial scene, the HO ordered a CTG as well to assess the baby's well-being. Trans-abdominal scan also we can do initially, whether to check whether there is IUGR, and the input-output chart is specific in this situation because these mothers can easily go to fluid overload if we give increased fluid amount. So the recommended amount is around 80 to 100 per hour, 80 to 100 cc per hour. So we can monitor the input and output chart as well. And from the output, we can get an idea whether the patient is going into AKI or not as well. So the management of this patient's hypertensive situation, this patient was given oral labetalol 200 milligram stat dose. Since she was okay and stable, we were able to give oral, and it was followed up with 200 milligram 6 hourly doses. And apart from this, if the patient is not very hypertensive and we can give oral, the other option is to give nicodipine 20 milligram. And yeah, there are intravenous preparations as well, like labetalol and hydralazine. These can be used in a very urgent setting where the mother is not able to accept oral agents. Okay, so the next scene we will have the senior registrar coming in to check on the patient. And here we have the house officer, senior registrar, and the patient herself.
So she is the patient I told you about.
Okay. How is her blood pressure now, Yusha?
Now her BP is 140/90, sir, and she doesn't have any symptoms.
Okay. So the blood pressure is reducing now, I guess, and we have monitor the patient's blood pressure every half hourly. If it is above 140/90, give her a stat dose of oral nifedipine and recheck the blood pressure after half an hour. If it is not getting control, inform me as soon as possible. Okay. Have you received any results of the investigations yet, Dr. Disha?
No, sir, we are waiting for the results, sir.
Okay, okay. When you trace them and when you get them, inform me. Monitor the input-output, restrict the fluid intake to 80 to 100 milliliters per hour, and then start the daily weight chart as well. Give her IM DEXA in case we need to deliver the baby if there's any problem going on. So how about her previous scans? Were there any abnormalities, Dr. Disha?
So previously 24th week scan was done and it was normal, sir.
Right. So shall we take her to the scan room? We'll do a scan. Mrs. Manisha, අපි පොඩ්ඩක් ඔයාගේ බබාව හොඳින්ද කියලා බලන්න ස්කෑන් එකක් කරන්න යන්නේ.
Hari doctor.
Dr. Dilshan, abdominal circumference is 247 millimeters. Plotting the chart and tell me.
Yes, sir. It's in between 10th and 50th centile.
Okay. The estimated fetal weight is around 1.3 kilograms and lico is adequate. Dopplers are also normal. Mrs. Manisha,
Oh, doctor.
ඔයා දන්නවනේ ඔයාගේ ප්‍රෙෂර් වැඩි වෙලා තිබ්බේ කියලානේ. එතකොට ඒත් එක්කම මුත්‍රාත් එක්ක ප්‍රෝටීන් එක ගිහිල්ලා තියෙනවා කියලා අපිට පරීක්ෂණ වලින් හොයාගෙන තියෙනවා. එතකොට මෙහෙම වුණාම අපි මේ தත්ත්වය හඳුන්වනවා preeclampsia කියලා තත්ත්වයක් කියලා. එතකොට මේ දෙකෙන්ම මේ preeclampsia තත්ත්වයේ හින්දා ඔයාටයි බබාටයි දෙන්නටම හානි වීමේ අවදානමක් තියෙනවා. අපි කරන්නේ ඔයාට බෙහෙත් දෙන ගමන් ඔයාගේ ප්‍රෙෂර් එකයි අනිකුත් අවදානම් ලක්ෂණ එනවද කියලා මොනිටර් කරන එක තමයි කරන්නේ. එතකොට දැන් අපි කරපු ස්කෑන් එකෙන් බබාගේ වර්ධනය ගැන බැලුවා. දැනට තියෙන ස්කෑන් එකෙන් නම් කිසිම ප්‍රශ්නයක් නැහැ. අපි ඉස්සරහට බබාගේ ස්කෑන් කරලා බලනවා. මේ ටික ඔයාලට පැහැදිලිද?
Oh, doctor.
ඊට අමතරව ඔයා කරන්න ඕන එකක් තමයි ඔයාට ඔළුවේ කැක්කුමක් හරි බඩේ වේදනාවක් හරි හුස්ම ගන්න අපහසුාවක් හරි ඇස්බොඳ වෙන ගතියක් හරි තිබ්බොත් අපි ඉක්මනට දැනුවත් කරන්න ඕනේ.
Hari doctor.
අපි ඊට අමතරව ඔයා දැනුවත් වෙන්න ඕන එකක් තමයි ඔයාගේ ප්‍රෙෂර් එක පාලනය වුණේ නැත්තම් හරි මම අර කලින් කියපු අවදානම් ලක්ෂණ ආවොත් හරි නැත්තම් ඔයා කරන අර අපි ඔයාගේ එක පරීක්ෂණ කරනවානේ ඒවල මොන හරි රිසල්ට්ස් වල නරක පැත්තකට හැරෙනවා නම් හරි අපිට කරන්න පුළුවන් හොඳම දේ තමයි බබාව ඩිලිවර් කරන එක. ඒකේ තමයි ඔයාටයි බබාටයි දෙන්නටම හොඳ වෙන්නේ. අපි ඉස්සරහට බලමුකෝ මොකද වෙන්නේ කියලානේ. තව මොනවා හරි ඔයාට දැනගන්න තියෙනවද මගේ?
No, doctor.
Okay, so we witnessed that the senior registrar scanned the patient, and we found out that the baby's growth was in between 10th and 15th centile, and the doctor, the senior registrar, explained the mother of her condition and counseled the mother as much as possible. And so now let's go into the continuous ward management of this patient. We are dividing it into the concerns we had regarding this patient. And I would like to mention that this is an actual patient who was in the ward. So we had specific concerns and we did monitoring and certain interventions, and there were specific responses to interventions which decided the future management of this patient. So the major concerns we had in this mother was the risk of having preeclampsia, and within the 2-week stay she stayed in the ward, she had persistently elevated blood pressure despite giving multiple antihypertensives. So her blood pressures were actually fluctuating throughout the day. In the morning, she had elevated blood pressure almost every day, despite being given nifedipine and other antihypertensives. And she also had continuous proteinuria of 2+. And additionally, since she was asked to bed rest, there was a high risk of developing a thrombotic event as well. And regarding the fetus, in the initial growth scan, it was above 10th centile, but with time, in the serial growth scans done to assess the fetus, the doctors have found out the abdominal circumference was just below 3rd centile after the stay of 2 weeks in this ward. So that's a specific decline, and the baby is now having severe IUGR. And so in order to monitor and investigate these conditions, we set up these investigations for the mother, we assessed the PET symptoms and signs, and we monitored her blood pressure 4 hourly, and urine protein ward test was done daily, and monitored the input-output charts as well. And also PET investigations such as liver enzymes and renal enzymes and whatnot, it was sent as well. And for the fetal monitoring, we also did, we asked the mother to monitor the fetal movements, and Doppler-aided fetal heart sounds were checked as well. and CTG was checked every third day, and transabdominal scan was also done with the Doppler, where the Doppler flow was okay, and this is where we found out the baby's abdominal circumference was less than third centile. And since we had all those concerns of this mother, she was initially given oral labetalol, which was increased up to 300 milligrams 6-hourly dose, and she was given oral nifedipine, initially stat doses, where she was found to have high blood pressure, but then it was continued on to nifedipine twice daily, 20 milligram twice daily dose. And as a last measure, since blood pressure was still not being controlled, oral methyl-dopa was added, initially as a 250 milligram dose thrice daily, which was increased up to 500 milligrams thrice daily. And she was also planned to give magnesium sulfate prior to surgery, where this surgery was planned since this blood pressure was not responding to 3 antihypertensives. And also for the thrombotic risk, she was given a subcutaneous enoxaparin 40 milligrams daily, and she was also given compression stockings as well. And since the delivery was imminent, considering the mother's condition, the baby was given dexamethasone 2 doses of 12 milligrams, each 12 hours apart. And now we'll go to the situation after the 2 weeks and after the management I've mentioned. In the ward rounds, the consultant and the house officer and the nursing officer are considering the situation of this patient.
Good morning, sir. She's 26-year-old coming in her second pregnancy with previous first trimester complete miscarriage. This time she was admitted with high blood pressure of 150 by 100 and proteinuria of +3 on admission, sir. She's currently on 3 antihypertensives, but still the blood pressure is high today. Morning it was 140 by 90. Proteinuria also was +2. PRET screen was normal. On serial growth scan, initially it was in between. Initially it was in between 10th and 15th centile, but now it's less than 3rd centile. Dexamethasone 12 milligrams, 12 hours apart, 2 doses given.
Okay, here's the problem, Dilshan. With this situation, patient can collapse at any time. So ultimate option is to deliver the baby. So did you start on her on megsulfate?
No, sir. Still we haven't started.
Okay, now you have to start on megsulfate and plan for the delivery by C-section. Inform anesthetist team, neonatology team, and inform theatre. And you have to inform pediatric medical officer regarding plan of the delivery today and see the availability of NICU beds. Okay.
Yes, sir. I do.
Okay.
Miss, මෙයාද section යවන්න ඕනේ. Grouping DT බලන්න. Blood count එකකුත් අපි repeat කරමු. මෙයාගේ rat එකකුත් ආයෙ කරන්න වෙයි නේද? මම අම්මට කතා කරලා consent ගන්නවා.
හරි ડોක්ටර්.
Mrs. Manisha, දැන් ඔයාගේ තත්ත්වය ගැන ඔයා මොනවද දන්නේ?
මට ප්‍රෙෂර් තියෙනවානේ ડોක්ටර්. ඒක මේ දෙකටම අඩු වෙන්නේ නැහැ. ඒත් එක්කම මේ මුත්‍රාවල ප්‍රෝටීන් තියෙන එකත් හොඳ නැහැ කිව්වා ડોක්ටර්. ඒ මැදට මේ අන්තිමට කරපු ස්කෑන් එකෙත් බබා පොඩි කියලා කිව්වා.
හරි අම්මා. දැන් තියෙන තත්ත්වය අනුව අපි බෙහෙත් වර්ග 3ක් දීලා තියෙනවා ප්‍රෙෂර් පාලනය කරන්න. ඒ වුණාට ඒකකටවත් හොඳට ප්‍රතිචාරයක් දක්වලා නැහැ. මුත්‍රාවල ප්‍රෝටීන් තාම තියෙනවානේ. ස්කෑන් වලින් බලපුවාම වර්ධනයේත් බබාගේ වර්ධනයේත් අඩුවක් පේනවා. දැන් මේ තත්ත්වය අපි දිගටම පවත්වාගෙන ගියොත් ඒක බබාටත් හානියක් වෙන්න පුළුවන්, අම්මටත් හානියක් වෙන්න පුළුවන්. පැහැදිලි නේද? ඉතින් මේකට තියෙන එකම විසඳුම තමයි බබාව ඉක්මනට ඩිලිවර් කරන එක. අපි දැන් බබාව සීසර් කරලා අරන් ICU එකට දාන්න තමයි අපි ලොකු ડોක්ටර්ත් එක්ක කතා වුණේ. සීසර් කරන්න ඔපරේෂන් එක කරන්නේ බඩේ යටින් පොඩි කැපුමක් දාලා බබාව එළියට ගන්න එක කරන්නේ. මේක කරන්නේ කොන්දට බෙහෙතක් විදලා කොන්දෙන් පහළ හිරිවැටලා තමයි කරන්නේ. බොහොම කලාතුරක ඉතින් ඔපරේෂන් එක වෙලාවේදී ලේ ගැලීමක් වෙන්න පුළුවන්. එහෙම වුණොත් අපි අම්මට ලේ දෙනවා. ඊට අමතරව මුත්‍රාශයට වගේ හානි වෙන්න පුළුවන්. එහෙම වුණොත් ඉතින් මුත්‍රාශයට බටයක් දාලා ටික කාලයක් ඉන්න වෙනවා. ඒ වුණාට බොහොම කලාතුරකින් තමයි එහෙම දේවල් එන්නේ. මොකද බොහොම පළපුරුදු ડોක්ටර්ලා තමයි මේ ඔපරේෂන් එක කරන්නේ. ඔයාලට මේ කියපු දේවල් පැහැදිලි නේද? මොකුත්
ඔව්
ප්‍රශ්න
ડોක්ටර්.
තියෙනවද?
ඉතින් අනේ ડોක්ටර් බබාට තම සති 32යිනේ. දැම්ම ගත්තොත් එහෙනම් බබාට මොකද වෙන්නේ නැද්ද? ප්‍රශ්නයක් වෙන්නේ නැද්ද? බබා චූටිනේ ડોක්ටර් තාම.
ඒක තමයි අම්මා බබා දැන් අම්මගේ බබා සාමාන්‍ය බබෙක් වඩා කලින් ගන්න නිසා පොඩ්ඩක් පොඩි තමයි. සති 32ක් නිසා එයාට ප්‍රශ්නක් සති 32ක්නේ. ප්‍රශ්නයක් නොවන තරමට අපිට එයාව බලා ගන්න පුළුවන්. අපි එයාගේ පෙනහළු පරිණත වෙන්නත් බෙහෙතක් දීලානේ තියෙන්නේ. අර ඉන්ජෙක්ෂන් එකක් දුන්නේ. අපි දැන් දැනටමත් එයාට ICU එකේ බෙඩ් එකක් එහෙම වෙන් කරලා තියෙන්නේ. ඒක නිසා එයාට කිසිම ප්‍රශ්නයක් වෙන්නේ නැහැ. අපිට ප්‍රශ්නයක් නැතුව අම්මවයි බබාවයි දෙන්නම බලා ගන්න පුළුවන්. අම්මට තේරෙනව නේද?
හරි ડોක්ටර් තේරුණා.
හරි අම්මා. එහෙනම් සීස කරන්න එක ගැන පැහැදිලි කරලා දුන්නා. සීස කරන්න කැමතියි කියලා මෙතන ලියලා අස්තම් කරලා දෙන්න පුළුවන් නේද?
හරි ડોක්ටර්.
Okay, so here we saw the house officer and the consultant making the decision to deliver the baby. And here the major reason was that she had uncontrolled blood pressure even with 3 antihypertensives with significant doses. And the baby is having now abdominal circumference less than 3rd centile. And there are other reasons for delivery when a woman is having preeclampsia, and the guidelines, the ISSHP classification, the guidelines suggests we can deliver the baby around 37 weeks if there are repeated episodes of severe hypertension despite being treated with 3 classes of antihypertensive agents. If there is progressive thrombocytopenia, if there is progressively abnormal renal or liver enzyme test, and if the mother is having pulmonary edema, and if there are abnormal neurological features, and any non-reassuring fetal status, of which we had 2 in this mother. So regarding the preparation, the house officer counseled the mother regarding what is being done, what the surgery is, and how it will be done, and what are the possible complications, and got the consent. Here we need the informed written consent. And I'll take you through some pre-op and post-op management. This is almost basically similar to normal pregnancy. We get the informed written consent, and we keep the patient fasting 6 hours for solids and 2 hours for liquids. And we have to get IV access and send for certain blood investigations like full blood count, liver function test, and PTINR, and specifically grouping and DT. And there are pre-medications which can be given. In this patient, oral metoclopramide 10 milligrams and famotidine 20 milligrams were given. And catheterization, usually it's done in the theater, but if an emergency, we can do it early and send the patient to the theater. And considering the pre-medication as well, if in an emergency, we can give the IV preparations as well. And we also can give prophylactic antibiotics, and we send the antibiotics with the patient to the theater, which is being given just before the surgery. And regarding post-op monitoring, we have to measure the blood pressure, heart rate, respiratory rate, and oxygen saturation in this patient quarter hourly for 2 hours, half hourly for another 2 hours, and hourly for 4 to 6 hours until the patient is well. And we have to keep nail by mouth if the patient is not tolerating, and if the patient, until the patient is well after the, if there's any no anesthetic effects. And considering fluid, we can give oral if the patient is willing and able to, and if not, we can give IV as well, around 100 cc per hour, and we have to make sure we don't over enthusiastically replace fluid. And pain management is specific in these mothers. We can, in this mother, we can give both PR and oral medication, and IM preparations like pethidine and fentanyl are available as well if the pain is very severe. And we have to mobilize the mother early, and if necessary, we can continue antibiotics as well. And specifically for preeclamptic patients, in the early postpartum monitoring, there is a high risk of complications for at least around 3 days. And we should vigorously monitor their BP and the clinical condition at least every 4 hours while the patient is awake. And it is said that it's better to avoid NSAIDs for postpartum analgesia if the patient is having any end organ damage, specifically AKI, or if the patient is having any other known risk factors for AKI as well. And after the surgery is done, there's the postpartum management. Since this mother, as I mentioned before, she can have eclampsia even after the delivery as well, up to 6 weeks. So we have to monitor the mother for PET symptoms and signs, and specifically the BP, either 4 to 6 hourly, and full blood count. And in this patient, methyl-dopa and ifedipine were emitted, and she was started on enalapril 5 milligrams twice daily dose. And since she had very high blood pressure levels and fluctuating blood pressure levels, there was a nephrology referral done for this patient. And after the delivery, the patient was debriefed about the condition and the outcome of the condition as well. And if we go to the neonatal condition, the baby was admitted to the ICU and due to developing respiratory distress syndrome. And the baby was on invasive ventilation. And when we requested by yesterday, now the baby, they are considering moving the baby to non-invasive ventilation, which is most probably CPAP. And also we got to know the baby was given surfactant and feeding was assessed. And now the baby is currently improving and doing well clinically. And so we'll end this session with the follow-up plan. At discharge, we can inform the MOH or the area PHM because, as I mentioned, there's still a risk of this mother developing eclampsia. So in any emergency, we can ask the patient to contact them and they have to be informed as well. In this patient, she was asked to be relieved in 2 weeks with certain investigations, and she was also asked to come to the nephrology clinic with urine protein creatinine ratio, serum electrolytes, and serum creatinine levels. And patient education was given regarding wound care since the lower segment cesarean section was done, and she was educated regarding breastfeeding. And contraception was also, she was counseled regarding contraception. And specifically, she was educated of the importance of preconceptional counseling because in the future pregnancy, since now she has developed preeclampsia in this pregnancy, there's a high risk of developing higher risk of developing pregnancy-induced hypertension and also a risk of developing preeclampsia in the future pregnancies as well. So this sums up our management of this patient, and she is now currently doing well, and the baby is also doing well. And I thank all the group members who acted. And also these are the references where we got the information from. So if it's okay, we actually have a small video of the participants. Is it okay?
Go ahead. Yes, please. I'm very